So, on behalf of the CME India and all fully supported by the USB team, I welcome all the audience who are tuned to have this one session that is basically on the CV risk reduction. So, straightforward, let me share the screen. So today, a very short description or a talk on this strategy for CV risk reduction in type 2 diabetes in the next 25 minutes. What is our agenda? I will tell you. The first thing is that in Indian scenario, you are well aware that the CVD attributes to nearly 25% of all deaths. And everyone is aware that the overall diabetes prevalence of type 2 diabetes is increasing in India itself. So we will discuss the diabetes-driven CVD, what are the causes, so how to do the risk management with the CVD, with the lifestyle modification, blood pressure control, hyperlipidemia management, antiplatelet therapy, and what to do with the pre-existing CVD, and choose anti-hyperglycemic to prevent CVD, and then we will conclude. So I think if you see here in the agenda part, it is you can just check it here that what are the agenda of basically on the lifestyle modification, blood pressure control, hyperlipidemia, and antiplatelet therapy, and how to choose the anti-hyperglycemic in the diabetics. It is well now, it is known fact that the pre-diabetic condition, the risk of cardiovascular disease remains to a great extent. You can see that the CVD is a major cause of comorbidity and death among patients with type 2 diabetes with coronary artery disease having the highest prevalence. And there is a paucity of research studies investigating both the prevalence of CVD and risk factors such as obesity among people with type 2 diabetes. So if you have got the impaired fasting glucose and the impaired glucose tolerance increases the risk of CV disease by 18% and 20% respectively. So this is a very, very serious data, you can say. So when you treat a case of diabetes, it is very, very important that you assess the cardiovascular risk factors in all patients. I am telling that in all patients at diagnosis and annually, and what you are going to target, that is the main risk factors. And these are basically dyslipidemia, hypertension, smoking, family history of premature coronary artery disease. You see the presence of albuminuria, you see the BMI and presence of hyperuricemia. So if you cover these main risk factors, I think we are doing a genuine job here. It is now I told that the CAD condition increased by 160%, CVD death by 132%, and heart failure 2 to 4 times in men and 5 times in women if you suffer from diabetes. So this is a very, very great burden. In the 2022, the concept of glucocentric approach, as I will tell, it has weakened now. Now, the previous concept of glucocentric approach is no longer valid. While tight glycemic control is backbone of diabetes, no doubt, the management recent trials have focused on cardiovascular risk reduction as a primary objective. So we find a contemporary 15 recommended a strategy which extends beyond glycemic control. But we must not forget that there are compelling and established data which support the benefit of long-term glycemic control in reducing the risk of microvascular complications and the importance of legacy effect is quite clear. So this point should not be ignored. And but we also are aware that the evidence from the CVOT is today demonstrating the CV benefits with certain diabetes medications, in particular the SGLT2 inhibitors and GLP-1 RH. They have a major impact to formulate the strategy to risk reduction in type 2 diabetes. These are studies like Singh India in 2014, then again Singh 2, and the old global that was Interheart and Interstroke. If you go the results review, you can see what are the main risk factors which cause MI or cardiac problem. That is, again, you can see different hypertension, obesity, dyslipidemia. So according to all the data, we have formulated the main risk factors. But the very important question is how to identify the highest cardiovascular risk patients. So you should look for ideal health behaviors of your patient, like physical activity at goal, non-smoker, BMI less than 25, and whether patient is taking fruits and vegetables in sufficient amount, fish, sodium intake, sugar, beverage, and whole grain. So these are the things you must see. It is well known that the LDL oxidation triggers vascular injury and inflammation, leading to all these pathophysiology like the foam cell formation, monocyte motility, endothelial adhesions, and the plaque instability, free radical production. So these are the things how it is happening. So if you go in the recommendations in the ADA latest one, what are the prevention of vascular disease and mortality recommendation? It is quite clear that the pre-diabetes is associated with highest cardiovascular risk. Therefore, screening for and treatment of modifiable risk factors for cardiovascular disease are suggested. So definitely, the risk-based screening for type 2 diabetes or pre-diabetes in asymptomatic children and adolescents in the clinical settings, you are well aware about that. But in asymptomatic patients, you must be aware that the routine screening for coronary artery disease is not recommended, as it does not improve outcomes as long as atherosclerotic cardiovascular disease risk factors are treated. And you see the level of evidence is grade 1. So consider investigation for coronary artery disease in the presence of any of these symptoms, like if patient is coming with atypical cardiac symptoms like unexplained dyspnea, chest discomfort, signs or symptoms of associated vascular disease, including carotid bruits, transient ischemic attack, a stroke, claudication, or peripheral arterial disease, or electrocardiogram has showing some Q waves. So then you should proceed for a screening. And we have lots of guidelines. Basically, this ESC, the European Society of Cardiology guidelines are very important. So we must be, and they say how to go for if patient has got moderate risk, high risk, or very high risk. So this slide is quite important. Your patient has moderate risk if it is a well-controlled, short-standing, less than 10 years of diabetic. There is no evidence of target organ damage and no additional atherosclerotic cardiovascular disease risk factors. So this is the moderate risk case. And if the patient with diabetes without atherosclerotic cardiovascular disease and severe target organ damage and not fulfilling the moderate risk criteria, it goes for the high risk. And very high risk, if there is patient with diabetes with established atherosclerotic cardiovascular disease and severe target organ damage, what are those? If the eGFR is less than 45, whether albumin is coming out or not, or whether it is the eGFR is 45 to 59, proteinuria, presence of microvascular disease in at least 3 different sites. For example, micronuria plus retinopathy and plus neuropathy. So if these are present, go think for the very high risk cases. So I think this slide is again very, very important. Very high risk patient with diabetes and established CVD or having target organ damage or 3 or more major risk factors or early onset type 1 diabetes of long duration more than 20 years. So this is how we categorize high risk, very high risk, and moderate risk. Then the lifetime CVD risk and treatment benefit estimation may be needed. So accurate CVD risk estimation is not a joke. I will say that it is not a very difficult task. But you can estimate the 10-year risk for the first atherosclerotic cardiovascular disease event, like the non-fatal myocardial infarction or CHD or death. And in clinical practice, it is widely done by these risk calculators that is available online. I will just tell a bit about that. But recently, the new calculators on European population have known as a score 2 and a score 2 OP. So this is how it is coming. But for our in Indian setting, let us see what is more important. In Indian setting, the one Indian study has showed that the Framingham risk score global CVD risk assessment model could stratify maximum number of patients into high risk for hard cardiovascular events. So these are other some very important calculators like the QRISK2 and JBS3 and FRS-CHD. So ACC and HA, atherosclerotic cardiovascular disease risk calculator, and WHO risk score calculator could identify least number of patients. This is from the study I'm quoting from the Indian Heart Journal. So in our patients, basically they show that they are ACC and HA risk calculators are not so important. Even the ideally country and risk calculator specific should be used. Relative risk specific calculator for a particular country that should be used. But if you are using some risk calculator online, like from the European or others, the Southern Asian, if you are using, then multiply the risk by 1.3 for Indians, and other Asians multiply the risk by 1.1, and for black, so you have to do this. But this is quite not. But RSSJ, what mentions is more important, I will say. And this is very easy. You go online, you just type this QRISK3, you will get this. There are few questions, and they will ask about the age, sex, other things, and you can very easily calculate the risk. So you can do that in that way. So this is how we are going to calculate the risk if you are at all keen to use a calculator. But in clinical practice, I have not seen that many of the physicians are doing it. So let us, this story ends here. So cardiovascular risk and risk factor treatment in patients with type 2 diabetes. Let us start this topic now. What are the RSSI ESI clinical practice recommendations? So current or previous CVD events, age, body weight, BP and pulse of patients should be recorded during their first and subsequent visits. And as I told you that RSSI recommends this QRISK3 are simple and effective tools for identifying and predicting CVD risk in patients with type 2 diabetes, and should be recommended for identifying the high-risk individuals. And patients with diabetes and CVD risk should follow the ABC treatment goals. So now the question is how to prioritize the CV risk reduction in type 2 diabetes. These are some few important things that when to do this coronary artery calcium test. The scoring can reclassify CVD risk upwards and downwards in addition to conventional risk factors, and may thus be considered in men and women with calculated risk around decision thresholds. And as far as this CCTA, that is contrast computed tomography coronary angiography is concerned, this allows identification of coronary stenosis and predicts whether CCTA improves risk classification or aids prognostic value over the CAC. Scoring is unknown. But carotid ultrasound systemic use of IMT is not recommended due to lack of methodological standardization and the absence of added value of IMT in predicting future CVD events. Arterial stiffness is commonly measured using either aortic pulse wave velocity or arterial augmentation index. There are some instruments which can measure it. And a study suggests that the arterial stiffness predicts future CVD events and improves the risk classification. And body fat stored in visceral and the other ectopic depots carries a high risk than subcutaneous fat. So you can go for the BMI or waist circumference like that. So commonly overlooked risk sometimes we miss. Suppose a diabetic patient who is having got migraine, there is a 2-fold increased risk of ischemic stroke and a 1.5-fold increase in the risk of cardiac ischemic disease. Many times we do not consider it. Suppose your diabetic patient has come with a periodontal disease. This is very well linked to the both CVD and atherosclerosis. So you look for that. And some other inflammatory conditions like the best evidence for chronic inflammation, increasing CVD risk is level for rheumatoid arthritis, psoriasis, and they increase if these are present, they increase CVD risk by approximately 50% beyond established risk factors. If the patient is having also the HIV, this goes 90% risk of lead and CAD beyond that. So these are very important few things. You should go also ask about the ischemic stroke. There could be some sex-specific, like preeclampsia and pregnancy-related hypertension are associated with a higher risk of CVD. And polycystic ovarian syndrome confers a significant risk for future development of diabetes. Patient of CKD, AF, NFLD, ED, COAD, OSA, these all are also associated with the increased risk. Like if your patient of diabetes is having erectile dysfunction, they have higher risk for total CV events. You can see 62% for AMI and 39% for a stroke. So my point is that while you are doing this risk calculation, you take history for all of these conditions. Now let us discuss how to optimize the cardiovascular risk management. What are the treatment goals that should be well known to us? Now, what are the miracle of diet? Let us start with the lifestyle modifications. Now, recently the new analysis from the PURE study, that is a prospective urban and rural epidemiological study, has come out where they say that the glycemic index is a key measure of dietary health. So people with a diet in the highest quartile of glycemic index had a significant 25% higher risk rate of combined total deaths and major CVD events during a median follow-up of nearly 10 years compared with those with a diet in the lowest glycemic index quartile. So you tell about the glycemic index to your patients to choose very intelligently. And now the pre-dimet studies is showing that the Mediterranean type of diet, if you are following, this gives you a 30% reduction in the risk of cardiovascular events. So in this pre-specified diabetic subgroup of this trial, 29% reduction in the primary 3-point composite outcome has been found. That is how the RSSD ESI clinical practice recommendations say about how to choose the carbohydrates, how much, proteins, fat, and diet pattern. So you can say here that in the 2021 or 2022, we can say to have a recommended, you can recommend to our patient to adopt a Mediterranean or similar type of diet. That is, you can see that this is very good class 1 recommendation. It is recommended to restrict alcohol to a maximum of 100 grams per week. It is recommended, you can see these are very important fact things, like these are all class 1 recommendations, that you eat fish, preferably fatty, at least once a week, and restrict the processed meat. Again, patients with mental disorder need intensified attention, and smoking cessation is recommended regardless of weight gain. So these are very, very important things which our patients can follow. So I told about the alcohol part. And this shows that the estimated percentage change in the risk of coronary heart disease associated with the isocaloric substitutes of saturated fat for other types of fat or carbohydrate. On average, if you increase 2% in the energy intake from trans fatty acid, if you're taking, this is going to give you 23% higher CHD risk. So this must be avoided. In the same way, this is very important slide. You see here, if you are taking a 7 gram per day higher intake of total fiber, it is associated with a 9% lower risk of CAD. 10 gram per day higher fire intake was associated with 60% lower risk of a stroke, and high fiber intake may reduce postprandial glucose responses after carbohydrate-rich meals and also lower triglyceride level. About the salt, if you are taking a salt reduction of 2.5 gram per day, that results in 20% reduction of atherosclerotic cardiovascular events. This is huge data. And the meta-analysis reporting that 11% lower risk for the stroke associated with 3 to 5 daily servings of fruits and vegetables, and of 26% with 5 servings of a day compared then with fewer 3 servings. So this is how much important thing. Like nuts, you can see here the meta-analysis showing there is a prospective cohort study that a daily consumption of 30 grams of mixed nuts was associated with a 30% lower risk of atherosclerotic cardiovascular disease. Fish and fish oil supplements. So studies indicate that eating fish, particularly fish rich in N3-PUFA, and at least once a week is associated with a 60% lower risk of CAD, and eating fish 2 to 4 times a week is associated with a 6% lower risk of a stroke. The second intervention which we can offer to our patients, that is the exercise. And I will not show too many slides here, I will never discuss that. But remember, this is a very, very important thing which we can show to our patients, that exercise induces mitophagy, that a gradient difference in mitochondrial color from green yellow to red represents healthy, stressed, and damaged or dysfunctional mitochondria. So what we are seeing here, that here a patient is sedentary. You can see here, what is showing this? Green to yellow. And here exercise recovery all happening, and if you exercise trend, it becomes fully green. So my slogan is make your mitochondria green by proper exercise. So this is very, very important point to tell. And now we have lots of evidence by doing exercise. You can have mitochondrial biogenesis, anti-inflammatory effect, vasodilation, and angiogenesis, all lead to cardiovascular improvement. Even if you combine aerobic and the resistance training, they improve insulin sensitivity. You see it in the tune of 70% and lower the HbA1c levels, something around 0.9% to 10.6 millipore per mole. So you can see this, if you're combining the aerobic and resistance exercise is so much important. And then all this lifestyle modification can very well lead to reduction in the all risks associated with the non-alcoholic liver fatty disease. So this is again a very important message. So recent evidence suggests that adequate physical activity may reduce the risk by up to 27%. And this is the only message I want to give here. And this is all well recommended by the European Society of Cardiology guidelines, latest one. Then, and second part is, after doing this lifestyle modification with the diet, which I already told, and with proper exercise, some drugs we should offer to reduce the risk in our diabetic patients. Suppose our patient is having hypertension. So it is well known that the risk of a stroke, myocardial infarction, and all-cause mortality is directly proportional to blood pressure. So one of the most important intervention is to achieve optimal blood pressure goal. Intensive control of blood pressure with appropriate drugs is a very important way. It is unique fact that tight control of glucose decreases risk of microvascular complications. Remember, if you have given a patient and I ask you which one is more important, a high blood pressure or high blood sugar, this fact is very unique, that if you only give a tight control of glucose, this will decrease risk of microvascular complications. But remember, the tight control of blood pressure reduces both micro and macrovascular complications. The message is quite clear. So tight control of blood glucose decreases the risk of microvascular complication, and tight control of BP reduces both micro and macrovascular complications. Now, European Society of Cardiology has given the screening and diagnosis of hypertension that is being followed. And we have also got our own RSSDA ESI guidelines. And I think just remember here that if the initial BP is more than 140/90 and less than 160/100, you start with one agent. But even in this case, if you are finding that there is albumin is coming out, you start with ACE inhibitors or ARBs. Otherwise, if it is not albumin is absent, then you can start only with one drug, that ACE inhibitors, ARB, CCP, or diuretics. So these are the main classes of drugs. But if the initial BP is more than 160/100, don't opt for one agent. You start with two agents. And if there is albuminuria or CAD risk, then start with ARBs or ACE inhibitors and add CCB or diuretics. So this is how we follow. And then assess the BP control and adverse effects. And this chart is well showing. This is from the standard of medical care of diabetes. Even the ADA 2022 is same, that if you are not meeting the target or adverse effects using a drug from each of these classes, consider addition of mineralocorticoid receptor antagonist. So this is how we manage the blood pressure. So I will again say that the treatment for hypertension should include drug classes demonstrated to reduce the cardiovascular events in patients with diabetes, and ACE inhibitors or angiotensin receptor blockers are recommended. First-line therapy for hypertension in people with diabetes and coronary artery disease, and multiple drug therapy is generally required to achieve blood pressure targets. However, combination of ACE inhibitors and angiotensin receptor blockers and combination of ACE inhibitors or angiotensin receptor with direct renin inhibitors should not be used. So this is well-known fact. So this is the same thing. Now, next point is, after controlling the blood pressure, you also look for the lipids. And we have got in the market the moderate intensity statin, where we can have an average LDL-C reduction of in the tune of 30%. We have got high intensity statin that give you a 50% reduction. Then the PCSK9 inhibitors, 60%, and PCSK9 inhibitors plus high intensity statin, 75%. And if you use this PCSK9 inhibitors plus high intensity statin plus ezetimibe, it is 85%. If you ask what is the moderate intensity statin therapy, that is atorvastatin 10 to 20, and the Rujuva 5 to 10, and high intensity is known as Rujuva if you are using 20 to 40 and atorva 40 to 80. So this should be quite clear. And things are quite clear today. How to proceed for that, how the recommendations for the treatment of dyslipidemia in diabetes. If the patient of your diabetes is at very high risk, like there is some severe target organ damage, already established atherosclerotic cardiovascular disease, you start with intensive lipid lowering and goal for at least more than 50% LDL-C reduction, and an LDL-C goal should be achieved. That is now is 55 milligram per DL. But if the patient of your diabetic is more than 40 years at high risk, lipid lowering treatment with an ultimate LDL-C goal of more than 50%, LDL-C cholesterol reduction and LDL-C of 70 milligram per day is recommended. So basically, we are on practice following this 70 milligram. And suppose a patient is age is less than 40 with type 1 diabetes or type 2 diabetes, but he or she have got the evidence of target organ damage, then a statin therapy may be considered. So this is how we proceed. And this is a bit about the PCSK9 inhibitors. They are recommended considering the cost effectiveness. I think regional context before you implement this is very, very costly drug. So I will not discuss it here. Now, only think many times we have got some confusion about the primary prevention recommendations. Again, the ADA in the 2022 says that for patients with diabetes, age is 40 to 75 years, there is no atherosclerotic cardiovascular disease, just use moderate intensity statin therapy in addition to lifestyle therapy. So this is quite crystal clear that even a patient with diabetes, but age is 40 to 75, there is no atherosclerotic cardiovascular disease. But in such cases also, now recommendation is to start the statin. Only thing is that if the patient with diabetes age is 20 to 39 years, but with additional atherosclerotic cardiovascular disease risk factors, it may be reasonable to initiate a statin therapy. So you see, they have given lots of importance to the statin now. It is quite clear at present. So I just told you about this. For secondary prevention, there is no problem. We all know that in such cases, you have to go with the lipid therapy that is well known and well said by other all guidelines. Even for the triglyceride issues, you should be careful that if the fasting triglyceride is more than 500, just go for evaluation of the secondary causes. And in patient with moderate, if 175 to 499, you address the treat lifestyle factors, secondary factors like diabetes, chronic liver disease, nephrotic syndrome, hypothyroidism, and the medication that raise the triglycerides. In patient with atherosclerotic cardiovascular disease or other cardiovascular risk factors on a statin with controlled LDL cholesterol, but elevated triglyceride in between 135 to 499, the addition of now they said that icosapent can be considered to reduce the cardiovascular risk. So here, a statin plus fibrate combination therapy has not been shown to improve atherosclerotic cardiovascular disease outcome and generally not recommended. So most of cases you will need only a statin. Even the statin plus niacin, it has not been shown to provide additional cardiovascular benefits. So to remember that. There is some diabetes risk with the statin. I will not discuss here. Lastly, I will discuss about the antiplatelets. And I think this slide is sufficient that use aspirin therapy 75 to 162 milligram per day as a secondary prevention strategy in those with diabetes and the history of atherosclerotic cardiovascular disease. So there is no second thought, you start it. For patients with atherosclerotic cardiovascular disease and documented aspirin allergy, you can use clopidogrel. And dual antiplatelet therapy is reasonable for a year after an acute coronary syndrome and may have benefit beyond this period. And the long-term treatment with dual antiplatelet therapy should be considered for patients with prior coronary intervention, high ischemic risk, and low bleeding risk to prevent major adverse cardiovascular events. So now, though they say that the combination therapy with aspirin you use with the low dose of rivaroxaban, you can consider it where in patients with a stable coronary or peripheral arterial disease and low bleeding risk to prevent major adverse limb and cardiovascular events. And this is also a level of evidence is so this is emerging, the aspirin plus low dose rivaroxaban. And as far as the primary prevention strategy and use of aspirin therapy is concerned, in those with diabetes who are at increased cardiovascular risk, after a comprehensive discussion with the patient on the benefits, and you just see, compare with the comparable increased risk of bleeding, and then you assess it, and then you can start it. So I think this is quite clear here. You went to go for the aspirin for the primary prevention. So I have discussed it. So combination antiplatelet and anticoagulant therapy, combination therapy with aspirin plus low dose rivaroxaban is emerging. I told you, you went to consider it. Now also you go and see for the peripheral arterial disease. This is very, very important. So in patient with this lead and DM, strict glycemic control is recommended, and ACE inhibitors or ARBs should be considered in patient with diabetes and chronic symptomatic this LEAD without high bleeding risk. A combination of low dose rivaroxaban and aspirin may be considered, and you can see this is well documented in the guideline of the European Society of Cardiology. Last point is using SGLT2 inhibitors for the severe risk reduction. shift from cardiovascular safety to cardiorenal benefit of oral hypoglycemic agents. It is a big story, but I will only say here that CV disease remains the leading cause of morbidity and mortality in patients with type 2 diabetes. And considering this fact, the development of SGLT2 inhibitors and GLP-1 RH has for the first time demonstrated that a specific glucose-lowering therapies can directly improve CV outcomes. So today, the SGLT2 inhibitors with demonstrated CV benefits is recommended for patients with type 2 diabetes and heart failure, especially heart failure with reduced ejection fraction, or who are at high risk of developing heart failure, DKD, and clinically evident atherosclerotic cardiovascular disease, or any combination of these conditions. And if you are using, you can use GLP-1 RA with demonstrated CV benefit is recommended for patients with established or very high risk for the atherosclerotic cardiovascular disease. But now it also appears reasonable to use both SGLT2 inhibitors and GLP-1 RA which demonstrated CV benefit concomitantly if clinically indicated, even though such combination therapy has not been studied for CV risk reduction, and this has been now told by the ACC. So this is something new that is happening. So final takeaways are, when we have a patient with diabetes, part of risk factor management is of course glucose control. We want patient to know that their hemoglobin HbA1c, but for macrovascular disease, it is more important to manage other risk factors such as keeping the LDL low, very low, optimizing blood pressure, optimizing body weight, exercising, and avoiding tobacco products. And patients with diabetes have more rapid platelet turnover. They tend to have more platelet activation. And so in patients with diabetes and atherosclerotic vascular disease, patients are recommended to receive a single antiplatelet agent, generally aspirin. Although if someone is allergic to aspirin, they may receive clopidogrel monotherapy. So this is how we have told about the lifestyle therapies, dyslipidemia, hypertension, and you follow the A, B, C, D, E. That is a unique mantra. A is HbA1c control that will tackle the macrovascular complications. B is the blood pressure control, which and you must consider for the ACE or ARBs. Then C is cholesterol, D is diet, and E is exercise. So I think this is how we make our strategy for CV risk reduction in a type 2 diabetic patients. So adherence to treatment, a healthy diet, and lifestyle modifications are important to lower lipid levels and reduce CV risk. Believe it. In patients with residual risk and hypertriglyceridemia, lifestyle modifications play a critical role in lowering CV risk. Appreciate it. And reducing CV risk requires a multifactorial risk reduction strategy. And there is a growing armamentarium of novel and emerging agents in the CV space. It happens. So a team-based approach and a multifactorial risk reduction strategy are the keys to successful lipid management. And this is art to tackle this thing. So this is a big concept. Thank you very much for patience hearing. So I will just stop sharing here.